Let's talk about anemias. When the mean corpuscular volume of RBCs is less than 80 and they are centrally pallor, so this condition is known as microcytic hypochromic anemia. The first cause of this anemia is iron deficiency. In iron deficiency, there is decreased amount of iron that can be due to chronic bleeding. In chronic bleeding, there can be GI bleed and menorrhagia. When there is a bleeding, so that means the iron inside the hemoglobin will be less because iron is an essential part of our hemoglobin molecule. So the another condition can be malnutrition, absorption disorders, GI surgery, that can be gastrectomy, or there can increase demand like in pregnancy. These all factors will result in decrease in final step in heme synthesis. In hemoglobin, each subunit contains a heme group and each heme group contains an iron atom that is able to bind to one oxygen molecule. So when there is decreased amount of iron in heme, that means decreased amount of hemoglobin, while on lab findings there will decrease iron and increasing total iron binding capacity, decrease ferritin, that is a storage form of iron, and increase free erythrocyte porphyrin, microcytosis, and hypochromasia, that is a centrally pallor condition. The symptoms of iron deficiency anemia will include fatigue, conjunctival pallor, pica, that is a consumption of non-food substances. Another name for this condition is Peterson-Kelly syndrome, and spawn nails, that are chylonychia. Other manifestations of iron deficiency include glossitis, cheilosis, that is a painful inflammation and cracking of the corners of the mouth, Plummer-Vinson syndrome, that includes iron deficiency anemia, esophageal webs, and dysphagia. These are the three triads of Plummer-Vinson syndrome. So basically the absorption of iron occurs in the duodenum and proximal jejunum. Let's talk about some clinical correlates. The diagnosis of iron deficiency anemia requires that a patient be anemic and show laboratory evidence of iron deficiency. Red blood cells in iron deficiency anemia are usually described as being microcytic, mean corpuscular volume less than 80, and hypochromic. However, the manifestation of iron deficiency occurs in several stages. Like if the patient's only iron is decreased in the blood, that doesn't mean this patient is anemic. If the iron is also decreased in the hemoglobin molecule, that means the patient is anemic. Okay, another clinical correlation is that if iron tablet toxicity has been occurred, so on microscopic examination of hepatic tissues, we will evaluate lysosomal degradation. The mechanism is the peroxidative decomposition of cellular membrane lipids is a postulated mechanism of hepatocellular injury in parenchymal iron overload. The peroxidative degradation of the lysosomal membrane and the resultant release of hydrolytic enzymes may be responsible for hepatocellular injury in iron toxicity. The iron tablet toxicity also causes gastric bleeding. Let's talk about another clinical correlation. When there is an 18-month-old boy who is chubby and have weight above the 90th percentile, so the answer is this patient has iron deficiency anemia.